In healthcare, there is often too much information and not enough time. Here at the Melanin Initiative, we avoid TMI by breaking things down into language you can understand. We create a safe space for you to ask your questions and share a nursing perspective without taking up too much of your time. We're so excited to welcome back for a second time Dr. Shafana Turner. She's an anesthesiologist in Maryland and also the founder of Caring for Us, a nonprofit health literacy organization. In her first episode, we learned all about her journey into anesthesiology and her motivation for creating Caring for Us and how it can benefit you. Today, we're going to focus on a popular topic and one, like I mentioned before, I've been eager to do and address because not only my own patient, but even my family have had quite a bit of surgeries recently. And I notice when we tend, as a society, we focus on the surgery, the labor, the wedding, when those are just a blip in time compared to parenting or the marriage or the post-op period. And people are, it's just managing your expectations on, you should still prepare for those moments in life, but also prepare for the much longer duration. And so this is a very important topic, a big one when it comes to safety, and decreasing fear, because sometimes the recommendation is surgery and people will prolong that because of the fear around some of the things that we're going to address today. So it's a very important topic, and we're so grateful that she's been kind enough to share her time and her talent with us, and hopefully address some questions that you've had. If you're new here, welcome to the Melanin Initiative. I'm Dr. Kimberly Madison, a doctorally prepared nurse practitioner, and one of your co-hosts here at the Melanin Initiative, along with Alicia and Geraldine, who send their love in their absence. We're a health literacy podcast offering our nursing perspective. When we say health literacy, we're talking about your ability to obtain information, to understand that information, and then to use it to manage your health and advocate for others. It's our hope that by watching on any of our platforms, that you'll feel empowered to ask questions, educated on how you can manage your health at home, and confident to navigate the healthcare system. Our other mission is to elevate the voice of nurses, to bring awareness to all the different professions and roles within the healthcare industry, and to inspire the next generation, whether that next generation is coming right out of high school or starting a second, third, or fourth career. We know people are entering this industry every day from every age. We want to provide you a point of reference, give you something else to look to get answers from besides TV sitcoms, and introduce you to people who might be in your neighborhood. They might be a future colleague, a mentor, a partner, an entrepreneurial partnership. And so we just want to share journeys. We know it's really powerful when you can hear people's testimonies. And so often we see where someone has gone at the end of their journey, not realizing or even relating to the fact that they're right where you're from. They have the same concerns that you have. They're still trying to figure it out just like you're trying to figure it out. And sometimes that's all the motivation we need to keep trying. Remember, this show is for educational purposes only. Our opinions here that we express are not a representation of any of our affiliations. If you might be having a physical emergency, we recommend that you contact your personal healthcare provider. You can call 911 if you think you're having a physical emergency. And if you or someone you know might be having a mental health emergency, you can call 988 or text 741-741. And remember, we want you to leave comments, subscribe, share this content with your friends. It really helps the algorithm see that this information is important, so that when people like you look for topics like this, we'll show up higher in the search results. Dr. Turner, welcome back to the Melanin Initiative.
Thanks for having me again.
For those of the audience who haven't seen your first episode, we're going to send them over there. But if you could give us just a quick little elevator pitch on who you are, where you're from, and what you do.
I am an anesthesiologist. I'm at the University of Maryland right now, practicing there. I'm from North Carolina. We're originally born and bred, but I went to Hampton University, then to University of Maryland or University of North Carolina, Chapel Hill for my medical school and my anesthesia training, and then moved from Maryland or North Carolina to Maryland. And I'm sorry.
Oh, you're fine.
Sorry, I dropped my microphone. And then yes, so I've been here. I've been here ever since 2009.
And so someone calls up and says, hey, we decided to give someone a 2-week vacation and you won. Where would you go and what would you do?
Ooh, I really love Jamaica, but it's a very specific resort in Jamaica, and I won't tell which one it is because I don't want everybody to flood and then I can't get there. But I love, I love the culture. The people are super cool. They cook so well, and because and I don't think a lot of people know this unless either are from Jamaica or you really learn about it. But there's a huge Chinese influence in Jamaica as far as food and some of the culture and things like that. So just it's a very interesting, beautiful place. So I spent 2 weeks there at my resort.
Okay.
Mhm.
And then someone's coming to your town for the first time this weekend. What should they do?
Into Maryland or to North Carolina?
Actually, I'll let you pick.
I mean, Maryland is easy because I'm in Prince George's County, so I'm down the street from Washington D.C., and then 40 minutes north, Baltimore, and a little further you can get to Philadelphia, easy other things. But what to do around here? I mean, obviously going down to D.C. to see the monuments, um, the food options, just because this is kind of one of those center of the world type places. So the cultures and things like that. So the food options are absolutely. I don't think you can go too many places and not be surprised with what you're going to find. And then it's getting a little chillier now, but there's lots. Maryland is a very green place. There's lots of hiking, biking is a huge thing, and they're doing better with making the cities more livable, especially cities where there are more black and brown people, and so creating bike lanes and things like that. So, um, yeah, and then we love comedy clubs. Me and my husband, comedy clubs are our thing. So finding it's a new comic, somebody we've never heard of, like let's go check them out and have a couple of overpriced drinks.
Yeah, you mentioned the biking and the trails. Yes, so much green space, really wide paths. And so,
Mhm.
yeah, if you are new to the area, you don't have to rent if depending on where you're staying, you don't need to rent a car. You can get away with certainly Uber, there's a bus, there's the metro, there's the bikes and the scooters.
Yeah,
Of course, we're talking to someone who works in the OR, so you make sure you wear your helmet.
they're
uh,
trying to outlaw them in some places, the scooters.
huh?
Because they're trying to outlaw the scooters in places because so many
Oh,
people are getting hurt. Yeah, so many closed head injuries are happening.
oh. What about the bike?
I mean, well, the bikes you're pedaling on, but the scooter, because those things can get up to like 13 miles an hour,
Yeah,
and um, yeah, and little it's a scooter, so people think of them as something for like little children or whatever, so they're not as careful in how they move. I think there's something inherent about a bike for most people that you follow some rules, but it's a scooter, who cares? And
mm-hmm.
boom, they fall, and here they are in the operating room with me.
But you can get around really easily. One of my favorite restaurants is Planta. They have a location in DC and Maryland. It's a plant-based restaurant, and they only use like real ingredients.
Mm.
So I don't think they have any like impossible meat or anything like that on there. And then you
Okay.
mentioned hiking. We love the Shenandoah Trail. You can
Mhm.
also go access that in Virginia or Maryland,
Mhm.
and they have different levels of intensity. So yeah,
Mhm.
love those
Yeah.
recommendations. Thank
We
you.
got Bacon Ridge. They have a car graveyard down there. They have all these old cars that
Mm,
somebody deposited down there, like really, really like 1940s and 50s cars that are like in various stages of decomposition. But it's a cool like you're walking for an hour and then you see all these old cars and just have a moment to stop and just look.
And where is this?
Bacon Ridge. I think it's in like near Crownsville. Um,
Bacon, like the meat.
Bacon, like yeah, like
Oh,
pork loin, Bacon Ridge.
oh, nice. That sounds cool. Sounds like a great Instagram moment. Are they like in good shape?
Are we in good shape? I
No, the
mean,
cars.
oh no. They're old. They're rusting and falling apart, and
Oh,
they're it's a ridge, right? So they're like going down almost like down the mountain, and so it's just a really it's. I don't know if anyone did it on purpose or they just happened to find this place, and then they when they cut the trail, they just cut towards the cars, but. It's really when you get a chance, Google Bacon Ridge in the car cemetery.
oh, okay. Well, thank you for sharing that.
Hmm.
So let's get into our topic. You talked a little bit about this in your first episode, but we'll just want to do a little refresher. What
Hmm.
is the role of an anesthesiologist during a medical procedure?
Sure. Well, technically, we're called like perioperative medicine doctors. Critical care and perioperative medicine, meaning that we take peri means something around. Because I think when people think of anesthesia, they only think of like in the operating room.
Mhm.
But there's a whole lot more into taking care of you during that time than just like that day in that moment. So we get calls, referrals, questions asked from surgeons about their patients before, 2 and 3 months before surgery. They'll call, I have this patient that has this and this and this situation, this, medical condition. What types of workup do they need before they come in? What things need to be fixed or, managed, improved, or whatever before they have their surgery. So we prepare the patients in whatever way, as far as information and planning before the surgery, and then the part that people think of is, during the procedure. And if you go to my website, caringforus.org, the four is the letter four. I have a page in there that talks about anesthesia. And one of the things that I make sure patients understand is there's different kind of levels of anesthesia. So, there's like minimal sedation, moderate sedation, deep sedation. So depending on what the procedure is, I have to make sure I explain to patients what their expectations should be. So for something like a colonoscopy, I probably am not going to do the same type of anesthesia, like the same type of management of your breathing and some of the same medicines as I would if you were going to have like brain surgery. So colonoscopies and brain surgeries don't need the same level of anesthesia, and so I'll let patients know that you might hear something. It doesn't mean that I did my job poorly. It doesn't mean the medicine stopped working. It's just the level of anesthesia that you're on. If you think of like levels of sleep, we've all had those moments where you're asleep, but you can hear something in the room. Someone opens the door, or maybe you pass gas and you wake yourself up out of your sleep. Just kind of being real as a physician here. But then there's the sleep where like someone can come and rob you and your whole house, and you wake up in the morning, you're like, why are the sheets off the bed, and why am I? You were in that level of sleep. So anesthesia is the same way. And then we have the care of the patient after the surgery, so the recovery room, or the PACU, post anesthesia care unit. And so we're there, making sure that not only are you waking up okay, but all the other parts that are important to managing a patient after surgery. So is your pain being well managed? We take care of your glucose. So patients that are diabetic and things, we're still monitoring your glucose, monitoring your blood pressure, monitoring vomiting and nausea. That's a really big one that we have to deal with. So there's that part. So that's why I say it's perioperative. It's not just the operating room. It's the beginning, the middle, and the end. And then the critical care component. If you have to go to the ICU, we work in the ICUs as well, depending on level of training. If you go and do more training, you can go and work in the operating room. I mean, in the ICU.
Oh, okay. Is that like another extension of residency or fellowship?
It's a fellowship, right? So you finish 4 years of anesthesia residency, and then you can do an additional year of critical care medicine, where you only work in the ICU for a year. So taking care of patients in all kinds of medical situations.
Can you explain the difference between sedation and anesthesia in the simplest terms?
Sedation is, I'm going to make it so that you don't care, or you don't care as much. Anesthesia, in the sense that I think most people think of it, is I'm going to make it so that you don't even know what's happening. So, if you have a shot of tequila, for those who drink, you have a couple of shots of tequila, you can tell some funny jokes, you can trip and fall, and you may not care. Versus um, anesthesia, where you are out and we cut your body open, and you don't have an awareness of it, number one. And also we can suppress your body's response, because there's your the system in your body that helps you sense your environment, so that helps you sense your world, is your central nervous system. So there's your brain, and then you have all the nerves that you kind of feel on the outside. But then there's a part in the middle where your spinal cord is, and so your spinal cord can, in some spaces and places and times, actually can operate without the brain. And so when you touch a hot fire, right? When you touch a hot stove, that's an example we give. You pull your hand back before that signal actually gets to your brain, because your spinal cord actually is modulating that signal and what to do with it. So in anesthesia, we suppress all of those systems. So your body is not stimulated at all. So we can, like I said, we can cut you and your blood pressure doesn't change. Right now, someone could scream loudly in your ear and it would make you jump and your heart rate would go up, because you sense that. we cut legs off of patients and boop, we stop your body from experiencing that trauma.
And so you alluded earlier that there's prior to the surgery, you hear from the surgeon. And so
Mhm.
this is kind of what we might consider like the pre-anesthesia period, right?
Mhm.
And so let's talk about what patients can expect during their pre-anesthesia consultation and why this is so important.
Well, first of all, how you plan on experiencing something, and this kind of goes into psychology and things. You look for things that confirm what your expectation is. So if you go in thinking that this is really going to hurt, it's going to be terrible, it's going to be scary, you will you will make that so. You will look for things in your environment to prove yourself true. And it's natural for all of us, right? So if you before you come into the procedure that day, if you've talked to your surgeon about what the expectation is for, let's say, pain, or what's the expectation for nausea or what have you, you can kind of get your mind ready for it because it may not be as bad as you think. I hate needles, which is the ironic thing about being an anesthesiologist. But what I have to do before I have to go get like a flu shot is I can't think about that moment because what I'll do is I'll rev myself up before it happens, and then they'll poke me with this little needle that for most people they're just like, "Are you done yet?" And I'm like, "Ready? Like, they're gonna kill me today with this needle," and I will make my body experience something that otherwise I could have probably, you know, toned down a little bit. So what can the patient expect? Number one, the surgeon should tell you what the surgery is and why you need it, and why you need it now. There's some procedures that maybe can wait, and there's some procedures that don't need to wait. Maybe there's a cancer that we need to take out now. Maybe there's an aneurysm that we can't let sit around because if it explodes, you could bleed, tragically on the inside. But maybe it's, you had a breast implant and it's looking a little funny, and so maybe we can wait a little bit. Do you have, are you dealing with a cold right now? Do you have a new diagnosis of diabetes and your hemoglobin A1C is 10? And if you go into this procedure with unmanaged diabetes, your surgical scar is not going to heal. So let's take a little time first and get your diabetes under control so that when it's time for your skin to heal itself, your diabetes isn't get in the way of doing that. So that's what the patient should expect. Know who you are as far as a patient, your medical conditions, your allergies, your proclivities for anything. I've had anesthesia before and I always get nauseated. I took hydrocodone before and it makes me pass out, sleep, and I can't wake up. That's the stuff that you bring in when you first, you know, you're on the books, you have your surgery planned. So what about these things do we need to deal with now? Is my blood pressure okay to go to surgery now? Is my diabetes okay? One of the big things that we have to collaborate with the patients and doctors are patients that are on blood thinners. So if you take aspirin, if you take Eliquis, Plavix, Coumadin, we don't see a lot of Coumadin anymore. These are blood thinners. Patients maybe have had surgery, strokes, they've had, heart surgeries. And so they give you medicine so that your platelets don't stick together and you don't make blood clots as easily. Well, if you're going to have surgery and we're going to cut you open, is it safe for you to stay on that medicine? And if it's not safe to stay on it, when do I need to stop it? And to make it even more complicated, if there is a cardiovascular reason why you're on it, now we got to contact your cardiac doctor, your cardiac surgeon, or your cardiologist, and say, okay, they can be off this medicine for 3 days, and then day 3 or 4 you have your surgery, and then day 5 we start it back up. So we have a lot of planning with a lot of people in some cases, in some situations. And then the last thing I'll say about it that has nothing to do with anesthesia necessarily is when your doctor wants to, you have a procedure that day, either you or the doctor's, the manager of the doctor's office needs to start looking into your insurance and whether and how it's going to be covered. Because that could take some time, meaning that the surgeon may have to prove that you need this surgery before the insurance company does it. So there might be either some other, imaging study that you have to get. Sometimes they want you to have another procedure first before they approve this procedure. So that day, go and start contacting your insurance company, or like I said, the office manager um, of the surgeon's office usually will have some information about that too.
Yeah, wonderful points. And in that conversation where the surgeon's telling you why this is so important, they are should also tell you the alternative of not doing it, right? Because you always have. I always tell patients, this isn't a prison.
Mm-hmm.
You have options, but there are consequences to both options, and we just want to make sure you understand what those consequences are and that you're comfortable with it. Because at the end of the day, it's a decision that you have to live with.
Yeah, yeah.
And then I know you're talking about like side effects and adverse effects. And I know sometimes, like I've taken care of, I mean, I get a patient from the OR and they're completely confused. And the loved one is telling me every time they get this kind of anesthesia, this happens. So
Mm-hmm.
talk a little bit about that.
That's called delirium, postoperative delirium. And there are two sets of patients where that's an issue. Little kids, so like 6 month olds to like, 4 year olds, they just wake up and they're just screaming. And, we have to ensure, make sure the parents know, like, it's not that they're in pain. It's not that there's something wrong. It's just that they're, it's not a conscious, intentional thing that's happening. It's very much like, it's almost like a reflex that's happening. Their brain is like, confused and I don't know what's going on and I hate this and I don't know where I am. So there are things that we make sure that we do, whether it's timing of medications, but a lot of times it's just comfort. So we get the parent back in the room and make sure we hug them or whatever, and then you just got to give it time. Um, to relax. And we have some medicines that we can use with delirium if it gets really, really bad, because the patient, especially little kids, they can hurt themselves. So they flail all around and they're in a stretcher with, bars. And so then they roll over and they pop themselves in in the head with the bar on the, the side of the stretcher. Or they can throw them, other patients can throw themselves off of the bed. If you've had a procedure, where, there's sutures somewhere, maybe you had a bone, broken that was set in a cast, we don't want you throwing all that stuff around and possibly opening up sutures or re-breaking a bone. Um, so yeah, we don't want you to stay in that kind of delirious, uncontrollable state. The other group of patients that we worry about with postoperative delirium are older patients, mainly patients older than 65 or 70. Um, those brains are a little bit different, and what I tell patients is, all the phone lines got disconnected. So you have a network of phone lines in your brain, and they all got disconnected. And as you're waking up from anesthesia, sometimes they don't reconnect to the line that they were connected to before. So we have to just wait for the system to put itself back together, and so it creates a lot of confusion. Um, but that confusion can lead to other things. Again, the patients hurting themselves, issues with breathing, but that's usually not one. But mainly, it can lead to long-term issues with cognition or long-term issues with thinking. Um, so if we have a patient that comes in that already has maybe dementia, which maybe some of your audience knows about, just kind of that confusion that can happen with age, they're more likely to have that issue with delirium, kind of just being uncontrollable and very confused. And, they keep trying to get out of bed. And you're like, Grandpa, you can't leave right now. What are you doing? You got to lay down. Grandpa don't hear you because Grandpa's not there. That's not Grandpa doing that. That's Grandpa's brain kind of doing its own thing until Grandpa's the center of who he is. His selfness can come back in and take over, and that takes time and medication.
Yes, time is a big one. And I also know some people, maybe not when they're so far, but I know a lot of times we'll keep people on oxygen a little bit longer to help get the anesthesia out of their system and encourage them to use the incentive spirometer. I've heard a lot of surgeons emphasize that also to help get the anesthesia a little more clear. Have you not heard that?
Well,
They used to tell us. They used
this is what I'll say. Um, Everyone thinks that they know what anesthesia is and what anesthesiologists do, and everyone is wrong. So the oxygen, the incentive spirometer, will do nothing for getting the oxygen, for getting the anesthesia out of your system. That's the first thing. Because there's IV anesthesia and there's the anesthesia that you breathe, right? So the gas that people think of, the IV anesthesia, that's your kidneys and your liver, and how will you metabolize these drugs. So the drugs stop working When, if there's a receptor up here that this drug is working on, the way that the drug stops working is the drug gets taken away by your bloodstream, and then it gets broken down by your liver and you pee it out. So breathing oxygen doesn't help with that unless it's affecting like your blood pressure, because you're not getting oxygen and your heart's dying and it's not pumping blood to your kidney and liver. As far as the anesthesia that you breathe, similarly, you got to just get rid of it from wherever it's working. That receptor that molecule is working on, you just got to get it away from there. And the thing about the gases in anesthesia is, for the most part, your body does not metabolize them. We don't have the enzymes to break these drugs down. So the way that you get rid of them is you breathe them away. The oxygen is not going to help you necessarily. You just got to take deep breaths and you got to keep breathing. So maybe give them less narcotic, because that'll slow your breathing down. The incentive spirometer helps because it helps them take bigger breaths.
Mhm.
But the oxygen isn't necessarily washing the anesthesia out of your body. Just blow it out. Like you're blowing out a candle, like you're blowing the smoke out from a cigar or something like that. You just got to blow it away.
Thank you for that clarification.
Mm-hmm.
But yeah, I can't tell you how many times I heard that. And then you mentioned the proof of surgery. So you mentioned talking about sometimes insurance will require people to have a different surgery before they have a more advanced one or more expensive one, right?
Yeah.
There might be a lot of data to show that the expensive one has less side effects, less downtime. We can keep going. In addition to that, sometimes surgery will, insurance will require that maybe you do 12 weeks of physical therapy before you do something, right? And so that goes along with what we always emphasize by seeking treatment earlier.
Mm-hmm.
You have put it off for 12 months already, and now you're going to a doctor or a provider that's telling you, well, now we need you to go do 12 weeks of therapy. You're not going to be a happy
Mm-hmm.
camper when you hear that. And then you still have to go, and then you say you do the 12, then you go back for imaging, then you go back for follow-up, then you go back for consultations. And look, it might be 2 years later,
Easily.
as
Mm-hmm.
opposed to having just gone in when you first had a concern. And of course, 2 years later, whatever the problem is, it's certainly probably worse. And so now we're talking even more risk associated with that procedure, cost, downtime,
Mm-hmm.
time away from work. So I'm so glad you brought that up. And insurance plays a big role. They seem to be this elephant in the room. We know they're there, but we don't know who they are, right? It's just a voice on the other end of the phone. And for patients, it can be
Right.
really
Because
frustrating.
they have a lot of control and a lot of power.
Yeah. And for clinicians, it's equally frustrating. And we know there's a lot of clinicians, providers out here spending lots of time on the phone or in the chart trying to present their case on behalf of their patient because they really want them to have this procedure and change their life. What kind of questions should patients ask their anesthesiologist before a procedure?
Hi, I'm Alicia from the Melanin Initiative podcast. Our mission is twofold. One, to simplify complex health information so you feel empowered to ask questions, educated on how to manage your health, and confident to navigate the healthcare system. And two, to elevate the expertise of nurses, spotlight the diverse career opportunities within the healthcare industry, and inform our peers how to leverage their expertise as clinicians and entrepreneurs. In less than 2 years, we've grown to over 50,000 views and 1,000 downloads, with an international audience spanning the US, Canada, the UK, Australia, and more. Our engaged listeners are professionals, entrepreneurs aged 25 to 44 who value authentic, impactful content. Want to connect with this dynamic audience? Advertise with us. Send in your 1-minute video ad and let's amplify your brand. Email tmi.melanin@gmail.com for rates and details. Let's work together.
Well, I think the question that all patients have is, and I just don't want to hear anything. Am I going to be asleep? Right. So, ask the anesthesiologist, what is their expectation of how asleep you will be? Because sometimes making you all the way sleepy or keeping you from being aware is not the safest thing to do. What I can do is I can make it so you don't care. And so, what I hope patients will understand, especially after listening to this, and people, is that usually your fear of a thing is more traumatic to you than actually the thing that happens. So I had a patient actually this week, and she was having a procedure on her leg, and we wanted to do a nerve block on her where we go to a nerve in your body specific. So you got in your arm, you got these big nerves that go down and give you innervation to your arm. Easily to kind of think about is your teeth. We put numbing medicine in your gum to take a tooth out. And so I told the procedure she was going to have, I thought a nerve block would be helpful as part of her pain management strategy. So instead of, what people kind of traditionally think of for management of pain is narcotics, so oxycodone and fentanyl and, things like that. Dilaudid, some people may know about. But those medicines have a lot of side effects, right? So you're sleepy, you're constipated, you itch, you can get nauseated. Let's do something else so that we can use less of those other drugs. And in this case, I was suggesting a nerve block. Well, a nerve block involves putting a small needle through the skin, and then, like your dentist, we inject the numbing medicine. We just inject it near the nerve, and it was for her leg, so it makes part of her leg numb. Um, and she heard, needle, another needle, and she's like, "So you're gonna jab me?" And she's doing like this, and I'm like, I'm not gonna do that with anything on you today. Um, I said, but I need you to relax because you're gonna work yourself up. I promise you, I'm not gonna hurt you more than you can tolerate. I said, you have an IV in your arm right now. She had a big old IV right here. I said, was that terrible? No. And I said, would that make you leave the hospital right now if someone said you had to get another IV? I said, no. I said, so you handle that. You can handle this. You can handle it. And I'm going to give you medicine to make you not really care anyway. And so that's what, while we were sticking her with the needle for the nerve block, I gave her some relaxing medicine. This one is called Versed, which I'm sure you know about. It's in the same class of drugs as like Xanax. People know about Xanax and Valium. It's the same type of drug. So I gave her some Versed. We're down here sticking her with the needle. She's up here having conversations about cartoons and didn't know anything or care anything about what we did. And so that's, you know, the conversation you have with your anesthesiologist. I am not going to let you stay in trauma and stay in pain. And if there is a moment where we have to let you sit in that space, it's for your safety. Because if I do take away your pain, I could make you more unhealthy, whether it's your heart or your breathing. Um, so yes, you can ask them like what their expectation is for how aware you'll be, what the expectation is for how much pain you're going to be in. That's a question that you should have asked your surgeon way before you got here. Because again, I'm going to take care of you in the operating room and briefly in the recovery room. And you might not only be in the recovery room for 2 hours, but you're going to be up on that floor with the nurse who's going to take care of you and have to call the surgeon when you need more pain medicine for maybe a couple of days, or you're going to go home. So that question about how long pain is going to be is for your surgeon. And then I think, if you have any major medical conditions, you can ask your anesthesiologist, how are you going to manage this? So, if you have a pacemaker, if you have an insulin pump, if you have diabetes, how are you going to manage these things while I'm asleep? I have really bad asthma. Is that going to be a problem, or how are we going to deal with that? So, like I said, you be the captain of the ship. I have these things. How are you going to make sure that they're either better or they're not worse when I leave here?
Yeah, that question of the pain one. As a nurse, I'm going to get on a little soapbox. So I feel like sometimes the surgeon. So I'm here for a consult for neck pain, right? And the surgeon says, I can do this procedure and it will alleviate that pain that you're experiencing right now. And that is true. That will likely happen. But that doesn't mean they will not have a different kind of pain, either in the short term, like the first 6 weeks maybe, or the 6 months, or some kind of a lingering pain, right? And so patients get so confused and sometimes angry and surprised when their pain is not at zero. And as nurses, we spend so much time managing those expectations about their pain post-op, because I don't think enough education was provided on the journey of the pain. And of course, the importance of moving, even though it's gonna hurt, but it will each day it gets better. And so that's my little soapbox on.
No, it's huge, especially like on labor and delivery, because we have a lot of young, undereducated patients that come in. Especially I work in Baltimore, and so they got really no prenatal education for real. I mean the resources may have been given, did they use them? So we have patients that come in and they want their epidural for labor immediately, and they don't want to feel anything. And so really intentional, like when I'm having the conversation with the patient and I hear someone say the word numb. Oh, when they put the they're going to make you numb. Nope. Stop. We're not saying don't use that word, not with me. My plan is not to make you numb, right? If you become numb, okay. If you have no pain, okay. I said, but that's not my goal, and I need you to adjust your goals, because you're having a baby, and big baby, little hole. The likelihood of you not feeling anything is low. Some people, and I tell you, if you don't feel any pain, God bless you, you were given a gift today. But most patients will feel something. Now, what I want to make it so that it's tolerable.
Mm-hmm.
So even after surgery, the patient's in recovery, and I go and check on them. How you doing? How's your pain? And they'll give a number. Let's say on a scale of 0 to 10, they'll say 10. But I walked over to them in their sleep. How's your pain at 10 in your sleep? I'm not saying you don't have pain, but is it a 10 really? So could you take a nap with that pain? Could you close your eyes and rest for a second with that maybe discomfort? Let's just try another word or something like that. And the same thing, like I said, on labor and delivery. If I put this epidural in you right now, um, if you can take a nap during a contraction, right? Or you might say, oh, I can feel it coming, but it's not the same pain. Are you going to feel pressure, right? Because I can't take, and that goes into a whole other set of physiology and things like that, but I can't take the pressure away from having a baby. So that pressure that you're going to feel down in your perineum, down in your bottom where the baby's coming out, can't take that pressure away. And we kind of need you to have that pressure. So yeah, it's a conversation about using the right words. There's pain, there's pressure, there's stinging, there's stabbing, there's itching, there's shock. No, and then I say, describe the pain to me. It's just pain. Well, I need more of a word if you can, because that'll help me to determine what to use and what my expectation is, so that I don't feel like I don't want to fail the patient either. I don't want you to be in pain, but I also know that there's some things that I'm not going to be able to fix. And like you said, it's just going to take time and healing for that to happen.
Yeah, pain is its own topic, right? And actually, there is a PhD student who's building her own pain lab, and one of the areas she wants to address is sickle cell pain. And so I've reached out to her. I hope that we're able to bring her on the show and talk about it. But yeah, there are so many different types of pain. Many times we've talked about on this show the disparities when it comes to pain management in Black and Brown communities. And so in our training, we're taught the pain is what the patient says, right? And we're taught that there's a difference between the presentation of acute pain, right? Just had surgery versus chronic pain. I've been living with this for 10 years. And so as clinicians, sometimes, even though we are taught all these things, we still make our own assessment and judgment about what level of pain the patient is in. And then patients have anticipatory pain. So when I ask them to give me a number from 0 to 10, 10 being the worst pain they ever felt, they anticipate it's going to happen. They anticipate you're not going to call when it is bad. They anticipate when I go to sleep, when I walk, it's going to hurt. So they give me these high numbers. Sometimes maybe it's not actually a 10. It's, their fear of that. And so when it comes to pain, like you said, they'll say, oh, I'm just in pain. I don't know. And so, yes, I say the same things. Is it burning, itching, stabbing, stinging, pulling, tight, dull, sharp? And so some people, they still will get very frustrated because I'm the 100th person asking them the question, so they don't answer. But for some people, it has been very helpful. And I tell them what you say. It helps me know what kind of pain you're having, because not all pain medicine works the same way. And while we might not be able to get you to a 0, we certainly can do better than a 10. And, our goal is that each day that you're moving and participating in your care, we get closer to that number. And some people, I say, what's your goal? What's a good number for you? Some people will say 7. And some people will say 2, and I want people know that by having this conversation with you. So yeah, pain, we can go on a whole time, but we really like to emphasize the fact that when it comes to communities of color, there's a huge pain disparity, and that there's a misconception amongst clinicians that based on the way people look, that they are naturally born to tolerate pain more than the others. And because we fail patients, particularly in the acute care setting of treating their mental health disorders, we tend to over-medicate them with pain. They're over-medicating with pain. And if we actually just address their anxiety and depression, they actually would probably plus pain medicine. And you said calling the surgeon. I'm just going to say, as a night nurse, if I call the surgeon, I probably don't have, I'm going to have a meeting in the morning with someone. I'm typically calling like the resident or whoever on
Or an
call.
NP, yeah. Yeah. I
Um,
feel like our patients with, the definition of pain, and the definition of pain that I teach my residents is the negative psychological experience of perceived noxious stimuli. And that's the real, I'm like, how come many words? But basically, you feel bad because you think your body's being hurt, right? Well, that's why people can be drunk and wake up with, bruised legs and have no idea how it happened because you didn't feel it because you were too drunk to have the psychological experience of it. Similarly, we have, and this was again back when I was in my training at Chapel Hill, we had a very large Hispanic population, so from Guatemala, Nicaragua, things like that, and very young people, and they were, they how labor happened in their community and what treatments were available for pain. They did not I won't say they didn't feel it because that's their personal thing. They didn't experience pain the way that, maybe an American, 35-year-old house mom, from the suburbs would experience pain. Because we would say that they have the mental, like the fortitude, and it's not a judgment necessarily. It's just that this is what they expect that it's going to be like, and it's like, oh, it, it's done. That's what it is. So the last part I'd say with regard to the psychological experiences is that sometimes when I treat pain, it's not always with pain medicine. In the recovery room, um, I say if the patient is shivering, they wake up from anesthesia and they're shivering. I say do not try to stop shivering because when you try to stop shivering, it makes you anxious because you can't stop, and then you're anxious because you can't stop shivering, and then you're in more pain. Like, what? I said, just don't try to stop shivering. Think of a Beyonce song in your head and sing it word for word so you can take your brain somewhere else so you don't focus on this thing. So I will treat the anxiety first. So sometimes they'll get Ativan instead of Percocet, instead of fentanyl or Dilaudid or something. Give them something to relax them. And then their pain scores will go down because they're not psychologically wound up and um, feeling it this way. And like you said, depression patients really get upset. They put me on Zoloft, and my back hurts. I was like, well, if you have depression and chronic pain can cause depression, it's just a vicious cycle. So let's see if we can get you, in a higher level of mood, and then we can maybe decrease your pain score. Not to say that we don't want to give you pain medicine, not to say that we don't want to treat some real, pathology, but let's work on and depression is real pathology. Don't get me wrong. But let's work on all the parts of this pain equation. And the pain equation is a complex equation.
Yeah, and sleep is another way we might help address the pain. And I
Mm-hmm.
always tell patients also to try to work with your nurse if they're like in a long-term setting, and you're going to get rehab every morning. Try to work with the nurse in advance of physical therapy coming, so you can participate, be more participatory.
Mm-hmm.
And then at night, try to work with the nurse so you can actually get a good night's sleep.
Mm-hmm. Ooh, yeah. It's,
They're cutting the grass.
mm-hmm.
They
I
just
had some stuff going on in my house before. I said, oh, God, come on, guy.
Oh, okay. And then while we do talk about this whole part of the pain population, there's also the people where we have to convince them to take it because
Mm-hmm.
they're so afraid of addiction and tolerance, and how you had mentioned you were talking about that. And so sometimes people will be like, I'm just going to tough it out, right?
Yeah.
But then not realizing like that it actually can be causing you more harm than good.
Mm-hmm.
And for most patients, if they don't already have a history of like addiction, most patients aren't going to be getting addicted to this medicine because it's already being prescribed for a short period of time. You already cannot get it more than what is safe. And each day that you continue to participate in your recovery, you're going to need it less. So naturally, you're going to start to wean off of it. And this part of your recovery is temporary. You only need it for this little bit of time. And we're going to work with you every shift to make that adjustment.
Right.
Um, and then you had mentioned also like the score of a 10. So some people keep saying 10 because they want the IV medication because the IV works faster, right?
Mm-hmm.
But it doesn't last that long. And you can't
Mm-hmm.
go home on that and you want to go home. And
Right.
so it's just a matter of finding that sweet spot so that you can make that transition. And we can find a pill that we can see while you're with us works well. So when you go home, we know it will continue to work well for the period that is being prescribed. So actually, I've had a lot of conversations with people who I have to convince to take the medicine because
Yeah.
they just want to lay there, because if I don't move, it won't hurt. But you can't, this is not a
You're
lot.
going to get pneumonia and you're going to get blood clots and
Yeah.
get out of here. Yeah.
Any advice for parents or caregivers? Well, you do see up till 2, right? Or yeah, 2 and older.
Yeah.
So any advice for parents or caregivers of children undergoing sedation to make them feel more prepared?
Yeah, so a big thing that we have, especially this time of year, because right now it's November, so depending on when people listen to this, we're getting into a cold and flu season, right? So, and little kids are in school now, so they keep a URI, or upper respiratory tract infection. They keep a cold, they keep a snotty nose, they keep that. So, first thing, if your um, child or whoever you're taking care of is planning or has a procedure planned, and they're starting to have symptoms, call the doctor. Hey, these are the symptoms that little Timmy is having right now. Fever, no fever, snot, is it clear? Is it, nasty looking or whatever? And just keep them informed. Making sure you just keep an eye on, temperature and stuff like that. For the most part, depending on the procedure, we will figure out a way and probably take care of the patient under anesthesia. We won't cancel, especially little kids, because it's like, when are they not going to be sick, right? So, but we just need to know the character of the symptoms. Um, Other things that are really important to ask about with children and even older patients, and the last one applies to really older patients too if they're having a respiratory. It's harder with an older person with a urinary, an upper respiratory tract infection. I am more likely to cancel a procedure. Um, just because the irritation of your airway after surgery could cause a whole nother host of problems. If you have a big laparotomy scar, so a big scar on your belly, and I can take care of you fine during surgery, but then we take the breathing tube out. Now you become irritated because of that breathing tube, and you're coughing, and you got a big scar on your belly. New sutures on your belly. Like, I don't think anybody wants that pain, and the scar dehiscing or opening up. So older people more likely. So be honest though, because that gets annoying. Patients lie. I'm going to be real Shafanya right now. People lie, and so oh no 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 no, I don't have these issues. I'm not. My cold was 3 days ago, and then you know you're coughing and wheezing and all kinds of stuff after surgery. Or I can even see on the ventilator that your numbers and your waveforms are off. Like something's not right, and you're having what we call bronchospasm, which is what happens in asthma while you're under anesthesia because you have an active infection. You have an irritable respiratory tract infection, and now I'm breathing gases into it and all kinds of stuff. And like, so now I got to keep you alive, and you could have just told me the truth before. So yeah, older people, just be honest about your stuff. And then the last thing to ask about with little kids and older folks is what you can eat around anesthesia. So we have very, very clear guidelines with the American Society of Anesthesiologists about what you can eat and the timing of it before surgery and sedation. It's harder to do, obviously, with especially little babies that are breastfeeding every 4 hours or whatever. So that's again, collaborate with your doctor on timing of the procedure because you don't want to have a 2 month old having surgery at 4 in the afternoon and they can't eat, so we try to get them a little bit earlier. If you have a patient that has maybe some kidney injury and you want to make sure they stay hydrated, we'll let you hey, you can have clear liquids, up until 10 o'clock, and clear liquids is, apple juice, ginger ale, water, tea with no cream in it, that kind of thing. So those are the couple of things to make sure you get in good communication with your doctor about. And again, any medications that you're taking chronically, confirm like all of them. These are all the medications I take on a weekly basis. Let's say, what should I stop now? What should I stop 2 weeks from now? What should I stop the day of, the night before? And what should I keep taking up until my procedure?
Are there any new advancements in anesthesia that you all are using to improve patient safety or comfort, or anything on the horizon, especially AI?
We are, I think, just with regional anesthesia, and that's not new. The an epidural is an example of regional anesthesia where instead of putting your brain to sleep, we put a part of your body to sleep. But we have, lots of patients with vascular disease and things, that we're worried about their heart or their brain going under general anesthesia. But let's say if you have end-stage renal disease, you need a fistula for dialysis. Well, we can just block your arm. We can put a nerve block in your arm, make your arm numb, give you a little bit of chill medicine, so that you don't care, but we don't have to do general anesthesia. There are even new advances in some of the medicines that we inject with regional anesthesia. So something called Exparel, which is a type of local anesthetic that lasts for like 24 hours. It can give you, kind of that pain relief or that numbness for 24 hours. And then, the issue with narcotic addiction and things like that. There's new medicines that come out that help with managing that addiction, but also patients have pain, right? So Suboxone, methadone, methadone's not new, but medications like that are, kind of being more comfortably used now, and we're seeing them a lot more in the operating room.
Oh, and you mentioned I had two things. One, when people first wake up, the anesthesia is still in their system, right? But they think because they're awake, there's no anesthesia or sedation. So it's like, I feel amazing. I love that surgeon. This is great. This is better than I thought it was going to be.
Mm-hmm.
And I say, I know. And then it's just like, by the time you wake up in the morning, though, you might have the anesthesia will have worn off some more and you might feel a little bit differently. So that's when I'm starting to have the conversation about let's take this pill so that when you wake up, you're not screaming. And so that was one thing you had mentioned I wanted to piggyback on because so many people, they're just like, this is
I don't have
amazing.
any pain, nothing. Thank you all so much. I'm like, I'll
And then
come back in 35 minutes.
one of the biggest questions is why do I have to stop eating and drinking before my surgery?
Yeah. So when right now, if you're eating a cookie and it goes on, we say, "Oh, we went on the wrong pipe," you cough, and that's I thought I turned this off, and that's your body protecting itself, right? So your vocal cords close up so you don't get stuff down into your lungs. But when I give you anesthesia and sedation, I blunt or I stop your body being able to have that response. Um, and so I put you to sleep, and if your stomach is full of cereal, let's say you had cereal, you eat cereal in the morning, um, that food could come up through your esophagus, which is the pipe that connects your mouth to your stomach. It could come up to your esophagus, and again, you don't have the ability to cough, and now that stuff goes down into your lungs. So now you have cereal and milk and digestive enzymes and things in your lungs, and that can lead to something called aspiration pneumonia or pneumonitis. Um, and now we got a whole nother set of problems. So do you need a ventilator? Do you need steroids? Do you need antibiotics? Usually not antibiotics. So that's why we don't want you to eat. Also, if we're doing surgery on your stomach, we don't want you to have a stomach full of food. And then we let's say there was an accident and they cut into your stomach and now you got cheeseburger all on the inside of your body. So yeah, we same reason when you have to clean your bowel out before you have a colonoscopy. Um, let's make this as successful as plan to make this as successful as possible and keep you clean.
Yeah, that's wonderful. And then I find that you just said something I was gonna. Oh, someone might say, "Oh, my surgery is scheduled at 4 p.m. tomorrow, and they
Mm-hmm.
want me to stop eating at midnight,
Mm-hmm.
and I can't drink any water." Now, first of all, we've been trying to convince them to drink water the whole time, but now that we've told them they can't drink it, now they're going to die of thirst.
Right.
Then one thing they used to tell patients is, "I know your schedule." So usually we don't really tell the time because things can change, and once you tell
Mm-hmm.
patients the
Exactly.
time, they get fixated. So we usually don't tell them the time, but sometimes they find out, right? Because the loved one wants to be present, and. So I say, well, if there's something might happen where the earlier surgery gets scheduled or postponed, and then they can move you up closer, we want you to be ready to go sooner. And
Mm-hmm.
so that's usually what I would tell them as to
Mm-hmm.
why we're still going to stick with the 12 o'clock. And I've
Mm-hmm.
heard that different surgeons answer this question differently, like whether it needs to be 12, 8, or 4 hours
Mm-hmm. It
of being.
depends on what it is. Right. So anything fatty and heavy. So think, cheese and protein, like animal proteins, things like that. That's 8 hours. And then 6 hours for like animal milk. So you have a latte or something. That's 6 hours. 4 hours with human breast milk, and then 2 hours with clear liquids. So for the patient that has their procedure late in the afternoon, you're very right because we had that happen last week where the patient's procedure was scheduled for 2. So she ate breakfast at like 4, and I think she finished at 4 in the morning or something. Well, the procedure before her got cut short, like by 2 or 3 hours, and we could have taken her back to the operating room like let's say 11, but because she had eaten, now we got to wait until 12, 12:30 to take her back. And I basically I can't give her anesthesia until it's 8 hours, right? Because if anything were to happen to her, that's what I tell the patients. You would probably be okay, but if anything were to happen to you, and it comes out, and it will come out that I knew that you ate, it's all on me. They are not going to care. Well, if the patient says she's going to be fine, I'm the expert. I have the medical degree. I have the state of Maryland says that I can practice here, and they feel confident I can do that. It's all on me. So yeah, I'm not going to put myself and my future on the line because you ate cereal. No, not going to do it.
What resources can people access if they want to learn more?
Yes. So the American Society of Anesthesiologists has a wonderful page for patients. So it's I think it's ASAHQ for headquarter, asahq.org. And there's a great patient education page, and it has all these wonderful prompts as far as questions for a frequently asked questions type of section for patients getting ready for surgery. I'd say, online there's some really great resources for particular medical systems when it comes to anesthesia. Um, Napa, I used to work for a company called North American Partners in Anesthesia. I don't work for them anymore, but they did have a patient education like videos, and one of them that I thought was really great was they talked to. It was like a kind of a simulated conversation between a doctor, an anesthesia doctor, and a pregnant patient getting ready to come in for either labor, so talking about epidurals, or a C-section. And so, they kind of had a conversation there. So there are resources there. And then again, ask your surgeon if they have access to the anesthesia providers that are going to take care of you for that day, and they can get you in touch and just have a phone call. We can easily make a phone call. It doesn't have to be a formal doctor's visit where you got to pay a copay or something like that. We can just give you a call.
Well, thank you. Those sound really, really helpful. And we just can't thank you enough for spending 2 episodes with us, sharing your journey, your motivation to starting your nonprofit, Caring for Us, and addressing a really important part of healthcare that a lot of us will have to walk down that line. And to be able to hear from you for an hour can be very calming and reassuring for the whole family, where they can all be present, where sometimes we have those appointments by ourselves. And so this is something everyone can gather around and maybe come up with more great questions that they will write down and take to their appointment. How can people, how can people connect with you?
So www.caring4us.org is my website, and there's a menu option at the top that says contact us and about us. Click that, and there's a little form, and you just give me your name and send me a quick message or whatever, and I will get it in my email, and we'll connect and talk. But I will say, don't if you're going to contact me about anesthesia questions, I'm going to be very, very general with you because I'm not your provider. I don't know your history. I don't know the surgeon or the surgery that's going to happen. So I can maybe give you some guidance on the questions you should ask, but I'm going to be careful with the trust that you lend to me. Yeah.
Wonderful point and great way to manage expectations. Remember, everyone, you can email us your questions or show ideas at tmi.melanin@gmail.com. If you haven't already, this is your chance to subscribe to our YouTube channel, Apple, Spotify, wherever you're listening or watching. Please take the time to leave us a comment and a review. It lets the algorithm know that this information is important, so that when people like you look for information like this, we'll show up higher in the search results. All the resources we mentioned today we'll put in the description box, as well as all of our social media contacts. At the time of this filming, we release new videos at Sunday weekly at noon Eastern on YouTube, LinkedIn, Facebook, Instagram. Shout out to Angie, our producer. And the audio we drop at 5 a.m. on all your favorite podcast apps, so that the night shifters can be the first to get something and not the last. And so our day shift friends have something to listen to on the way to work. And maybe one day someone will play it during huddle and tell us about it. Thank you all for watching. We'll see you next time.